1 year back. Then he developed pain in the central part of abdomen, which is sudden onset and 1 year duration, which is severe intensity and colicky type of pain, and recurrent and intermittent nature. Pain radiates to back. There is no referring of pain. Pain aggravated by taking food and relieved by taking analgesics and bending forward position. He noticed a lump in the left upper quadrant of abdomen. He noticed a lump in the left upper quadrant of abdomen, which is increased in size for 1 month and then static in nature, which is a 5 months duration.
Can you please go back and say more about the pain?
Patient was apparently asymptomatic 1 year back. Then he developed pain in the central part of abdomen, which is sudden onset and recurrent and intermittent nature of pain. It is colicky type with severe intensity since 1 year, and pain radiates to back. There is no referring of pain. Pain aggravated by taking food, relieved by taking analgesics and bending forward positions.
Can you, what are the mistakes in this? Just let me know. Is a pain? He said it's a colicky type of pain, and he said it's a pain radiating to the back. So, what does it mean? Which organ do you think is involved?
Pancreas or CBD stones or gallbladder stones.
No, he said it's in a colicky type of pain. So, colicky type of pain in any luminal structure. It could be an aerator, it could be in a small intestine. So, it's a colicky means it's an luminal pain. And you said you have mentioned pain is radiating to the back. Which luminal pain will radiate to the back?
Any pancreatic duct obstruction, any stones.
Stones where you mean pancreatic stones, pancreatitis pain. There must be something wrong. So colicky type of pain, intermittent, yes, agreed, related within a food intake or vomiting, all these things are known with a colicky type of pain. If you want to describe it as a pancreatic type of pain, that's a different pain. It's a dull aching, rather sometimes more severe, it is radiating to back. There should not be any contradiction here. Okay? Yeah, proceed. Go on,
pancreatic pain is never a colicky type of pain. I think here you are committing a mistake.
Patient noticed a lump in the left upper quadrant of abdomen and central part of abdomen, which is increased in size for 1 month and then static in nature, which is a 5 months duration, is associated with pain abdomen. History of nausea and vomiting present, which is associated with pain abdomen. History of loss of weight and appetite present. History of dyspepsia present. No history of fever, jaundice or hematemesis or melena. No history of altered bowel habits or mucus in the stools. No history of foul smelling stools or bulky stools. No history of cough, breathlessness or chest pain. History of malaise and easy fatigability present. No history of petechiae or bone pains. No history of gum or nosebleeds. No history of hematuria or urinary disturbances. No history of any trauma. No history of any other swellings in the body.
Whatever negative history you give, it has to have some meaning. It has to have some correlation with your diagnosis, whatever it is. So, yeah, you tell me the reasons why you have mentioned all these things.
History of nausea vomiting may be associated with pain, pancreatic pains when it is severe in nature, or associated with any gastric outlet obstruction causing.
Gastric outlet is different, pancreatic pain is different.
Yes,
Don't mix up.
If it is any cystic swelling compressing over the duodenum or gastric, may cause nausea and vomiting.
Okay. Why dyspepsia suddenly came? Why history of what exactly you wanted to say?
I have to rule out.
There is no need to mention each and everything. So probably some particular diagnosis you must have thought in this patient. Say pain in the central abdomen, and he has a lump in the left side of the abdomen. So that's the two main important findings. So you need to know the causative factors for this pain and this swelling. So those history points you need to mention. For example, you have mentioned there is no history of, instead of saying hematemesis, no history of melena, you can mention there is no history of GIP. You are allowed to say as a postgraduate, not for an undergraduate. And again, no history of altered bowel habits, mucocilious stools. Why specifically all this? You can mention there is no history of an altered bowel habits. And why do you think there is no history of all smelling stools or bulky stool history?
It is
Simply, you could have mentioned simply there is no history of any change in the bowel habit. That would have solved all your problems. Instead of mentioning so many no's, with one shot of answer, you could have finished.
Okay.
And in this, why you mentioned the history of trauma in the last year?
And that is most important.
If you have forgotten, you should not highlight it again. Should have mentioned this in the beginning. When you have mentioned this onset of pain is sudden, should have inquired about the trauma, right? So you have forgotten that, and you have brought it up in the last.
Okay.
Complaint of pain abdomen 2 years back, which is also acute onset and epigastric region and radiates to back. Same, it is aggravated by alcohol ingestion relieved by medication. It is not a known case of diabetic, hypertension, tuberculosis or asthma. No
How
history.
how can it pain will be aggravated?
Aggravated.
Okay.
No history of any previous surgeries. Family history not significant. He takes mixed diet, appetite is decreased, weight loss present, disturbed sleep present due to pain abdomen, bowel and bladder habits are regular. He is a known case of alcoholic since 20 years, taking daily alcohol of 90 ml, stopped 2 months ago. He is not a known case of smokers. And treatment history, he has taken treatment for this complaints in local hospital, taken analysis for pain. On general examination, patient is conscious, coherent and cooperative, not comfortable in sitting position. Patient is thin built and ill nourished. No signs of liver cell failure. Pale are present, no jaundice, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. ECOG performance scale is 1. No melanotic lesions or migrated thrombophlebitis or no mucocutaneous pigmentations. Pulse rate is 84 beats per minute, regular in rhythm, normal volume. Blood pressure is 120/70 millimeters of mercury in right arm supine position. Respiratory rate is 18 per minute, regular and abdominal thoracic in nature. Patient is afebrile. On local abdominal examination, on inspection, fullness noted in the epigastric and left hypochondral region. Rest of the abdomen is flat. Umbilicus is midline and inverted. No umbilical nodules are seen. Except for fullness region, left upper quadrant, rest of the abdomen is moving with respiration. On abdominal fullness located in the epigastric, left hypochondral region, horizontally oval in shape. Margins appears to be ill-defined. Surface appears to be smooth. Skin over the swelling is normal. No visible veins or pulsations or peristalsis. No scars and sinuses. Surrounding skin is normal. Left lower intercostal widening is present. Penile faces are normal. No renal angle fullness. No paraspinal swellings. External genitalia are normal. No fullness seen in the left supraclavicular fossa.
What is that left lower intercostal widening is present? What does it mean?
It is mainly in the left hypochondral region extending out to below the costal margins. So because of the swelling, there is widening of the intercostal space.
I don't know. First time I
So I think
widening.
this finding you have to elicit only the palpation, I believe. Intercostal widening, no.
Generally, on inspection it is visible, sir. So,
And when you have mentioned this abnormality in the abdomen has some fullness in the left abdomen and epigastric, are you able to see any margins or this? Why to mention all that? Fullness is fullness, and then you have to describe rest of the things. If you try to mention the margins, border, this and that, then it becomes a lump or swelling.
What is the intercostal widening?
See, the mechanical ballooning ball. What present is there, you are presented. Why it is present, we can discuss and answer.
Okay. Now,
Is it true?
interesting
No,
to
what-
the abdomen, right?
Dr. Ramulu, he has told there is intercostal widening is there. Is it true to say that it is there? If it is there, it is there. Then why it has happened? We can ask the question.
Okay, you have a photograph.
Because we are thinking pseudopancreatic cyst and all
Can you-
these things, there should
You
not
have
be
a photograph
costal
presented here?
widening should not be there.
Photograph of the patient. Is it there? should have enlightened that intercostal widening what you have seen.
అంటే intercostal fullness is reported. Either sign intercostal fullness is reported.
Definitely it is a controversial finding what we say.
Okay, let's go ahead.
Explain what is intercostal widening. Explain what is intercostal widening.
But I want to know that why intercostal widening?
Better try to skip. Go ahead.
On palpation, there is no local rise of temperature. Mild tenderness present over the swelling. A single horizontally oval-shaped lump noted in the left hypochondral and epigastric region, measuring 18 into 10 cm in size, extending vertically from left postal margin to 2 cm above umbilicus, horizontally extending 3 cm right to the midline to left posterior axillary lines. Surface is smooth. Margin lower border is defined and rounded. Upper border is extending below left coastal margin. Medial border and lateral borders are ill-defined. Forming consistency. Swelling is not moving with respiration. No horizontal and vertical mobility of the swelling. Finger inclination is possible below left coastal margins. Swelling is not bimanual palpable. Skin is pinchable. Plane of the swelling is intra-abdominal and retroperitoneal and knee elbow position. No extensile or transmitted pulsations. No hepatosplenomegaly. No other swellings palpable. No renal angle tenderness. Hernial orifice and external genital are normal. No supraclavicular lymphadenopathy.
On what basis you could say that there is no liver splenomegaly here? Hepatosplenomegaly. This could be the splenic mass. This could be a mass arising from the.
No notch is palpable over the middle border of the swelling, sir. And the finger incision is possible below the left coastal margins.
No, is it not premature to say that there is no splenomegaly in this case when you have felt a mass in the left hypochondrium? It is very early to say that. Conclude.
Swelling is growing.
Better not to comment. Better not to commit about that. You commit about the liver, it's okay, but not about the spleen.
And percussion over the epigastric region is resonant, and over the left hypochondral is a dull node extending from left 7th intercostal space to it continues with the swelling dullness. Liver span is normal. No evidence of free fluid in the abdomen. And auscultation, no bruit here. Bowel sounds are present. No general lymphadenopathy. Other system examination, cardiovascular system examination, S1, S2 are here. No thrill or murmurs. Central nervous system examination is normal. And respiratory system examination, bilateral air intake present. Normal vascular breath sounds are here. Decreased breath sounds here in the left lower zones. No adventitious sounds are here. And my provisional diagnosis, anatomically it arises from the retroperitoneum, probably pancreas. Most common pancreas is Pseudocyst of Pancreas. My differential diagnosis is Pseudocyst of Pancreas arising from body or tail of the pancreas or cystic neoplasm of pancreas. The fibrotic and dense granulation tissue, it becomes static in it.
What happens to many of the pseudocysts? What is the natural course of the disease?
Naturally, after 6 weeks, within 6 weeks, it may resolve by spontaneously.
Many pseudocysts resolve. Many pseudocysts resolve spontaneously. So that is what is asking. See, some of them may resolve without any intervention. Some of them progress. Some of them remain stable for some time.
Of greater than 4 weeks duration.
My question is, what is acute pseudocyst? What is chronic pseudocyst? What is pseudocyst?
Pseudocyst is acute fluid collection. In acute pseudocyst is collection, peripancreatic collection surrounded by granulation tissue in the setting of acute pancreatic interstitial edematous pancreatitis, which is of more than 4 weeks duration with no or minimal necrosis.
What is chronic? That is because edematous pancreas, great momentum, stomach, and all those things.
Phlegmon, we'll call it
That's also called as
pancreatic phlegmon.
Pancreatic phlegmon is also called as pseudocyst of pancreas.
Okay. How do you proceed?
Question. This is regarding the examination findings, sir. As he said, he can insinuate his finger, and simultaneously he said that on dullness, on percussion, dullness is continuity with the swelling. On palpation, he said he can insinuate the finger between the swelling and as well as the subcostal margin. And simultaneously he said there is some dullness on percussion that is continuity with that of swelling.
Splenic dullness is continuous with the dullness over the swelling, right?
Yes, sir.
That's what he said.
Yes, sir. He can insinuate the finger, and simultaneously he said that this dullness continuity with the swelling.
And maybe it is abutting the spleen. Then. Maybe it is abutting the spleen.
No, sir.
It's only absent. It is not spleen, but it is, the cyst is abutting the spleen.
My question is he contradicting his own?
The finding could be correct, yes. He is able to insinuate his fingers between the costal margin and the swelling, but still the spleen dullness is continuous with the dullness over the swelling because it's closely applied to the spleen. It's not contradictory. It's not contradictory.
What is your opinion?
Sir, over there they've asked me a question now because ultrasound gives good information regarding pancreatic parenchyma as well as calcification and a good amount of ductal anatomy as well with the new modern ultrasound. So what is the role of CCT? Would you do CCT or would you directly go towards an MRCP without doing the CCT in between? So in that case, what
there's
should
no
I
need
ask?
for a CT scan. The ultrasound gives a chronic pancreas. I'll be comfortable in doing it an MRCP because if there is a ductal communication, ductal changes, the stones and parenchyma, there can be a malignancy underlying. So we need to rule out all these things. Imaging, you are not wrong if you say CT scan also. You will not be penalized for saying a CT scan of the abdomen. No. But I MRCP.
This point is whether we should do a CCT or not.
Because
That's what I'm saying.
examiners are quite divided in this.
No division.
Nobody is going
That's what
to
I'm
fail you
saying.
on this point. Nobody is going to fail you.
Yes.
But in practice,
In practice, see, that situation dictates we can do, sir. If there is some mass-like lesion in the ultrasound, if you have some suspicious area, like a focus is there, which is suspicious, then in that case you have to go for the CCT approach.
Yeah, both are correct. Nothing wrong. Nothing wrong.
బాబు ఇంకా ముందు పోతే